3, 2,
Needle
1.
pod.
Needle pod.
Needle pod. I was like, you pointed. I didn't know if you wanted me to just go.
Welcome back to the mic. It's Needle Pod. It's Ellie and Paul back with you. Thanks for jumping on with our guest last episode. If you didn't listen to that, I mean, at the time of this recording, it just dropped today, but April Dominic, not just having a purely pelvic pod, but it was focused primarily on males. So if that is a interest and intrigue or a realm you'd look to sharpen your skills, April Dominic is your resource. I mean, Ellie, you see male pelvic health as well, but
yeah,
whether you want to talk needling or actually just the management or pathology, that is an episode for you.
it's so cool. So I actually spent this past weekend with her. You know, we live close to each other, so we like to work with each other when we can and like refine our knowledge. And she was creating, like finalizing all of her lecture slide decks and stuff like that. And she knows her shit. Like, it's really cool to see like how much information she has gained with diving into the research for this course creation. I think that's one of the coolest things when you are creating a course is you just learn everything so well. And then when you go to teach it, it's fun. So if you guys do have the ability to take her male pelvic course, I highly recommend it.
Don't let
Even
the
if you're
bubbly
not-
personality
Yeah,
fool you. She's a nerd.
she is. Yeah, she's great. So that was really fun chatting with her. I think we could have chatted for like a full hour, but I wanted to keep it timely.
I would just love, like, if you two were chatting at like a Starbucks, I would love to be just like at the table next to you just to hear how it goes. I mean,
It's so funny because we forget when we're around people that don't speak pelvic or don't speak PT. And with her developing the male course, she'll just drop like erection or premature ejaculation in the middle of public. And we're just like, oh, yeah. But people don't always vibe with that. So
do you
it's
ever get
fun.
harshed on Instagram or Meta, like for being obscene?
No,
Real
I haven't.
interesting.
Yeah. I also like, I don't post like pictures of pelvic floor needling or anything
sure.
like that. So I haven't done that. And my content right now on Instagram is mostly ice content versus like other. Yeah. So I think it's educational towards a physical therapist, but yeah, haven't ever gotten flagged, which is great because
For
needling
sure.
can get flagged sometimes.
Yeah, actually early on it's getting better, but yeah, just the optic of a needle in bare skin basically that actually used to get either like restricted or kind of down trended by the algorithm for being either a medical procedure or gruesome. I think that's changing, but early on in the eye dry needle days, we had to find creative ways to show like, maybe it was a needling procedure, but like from afar where it didn't look just like a zoomed in puncturing of human tissue.
Yeah.
But yeah, I think that's changed quite a bit. And I mean, my algorithm is dry needling and CrossFit. And so I'm just so used to seeing it pretty obvious and some pretty gnarly stuff out there. We don't have to talk about it today, but.
No, you see some weird stuff. Like, I think sometimes the cupping things out there on Instagram seem more aggressive than needle content. But yeah, we get a lot of weird stuff on the internet.
So today
Yeah.
we're tackling I guess it was a listener request, but it's an obvious one because it comes up on every dry needling course. And today I'm even going to funnel it to cervical, but we're going to talk radiculopathy and like dry needling for radics. So, I mean, let me paint the picture first of the younger patient, a more acute radic, a pretty specific traumatic event, whether it was a whiplash mechanism or, I'll get into my story in a minute, but most likely handstand push-up practice, but a pretty specific mechanism, a pretty acute, pretty direct cause, and a pretty obvious radic. I mean, there's a nerve pattern, there's some numbness, there's some weakness. I mean, a really bad one, is it a Bacody's sign? Like the alleviating position of propping your arm on your head. So again, cervical radic, acute younger, it comes up on every course. So first I'll toss it to you and say, what do you do with that human with your needling on first visit?
Yeah. So great question. And I think for needling, I like that you teed up, like, what do you do with needling? Because, offline, we were kind of chatting about all the things that we can do for cervical radics and stuff like that. But if we narrow it down to first session, trying to improve blood flow around the exiting nerve root, right? Getting some of that chemical irritant out of that space is going to be the number one priority there. And then also just improving kind of blood flow through the entire nervous system. in that upper extremity if their symptoms are, going peripheral all the way down to the hand and things like that. So I think when it's that acute flare up, there is straddling the segment versus going directly to the segment that's the radiculopathy. So
So if
if
it's
it
a
was
C6, you're above and below.
C5 and below, yeah. So hitting above and below, and then kind of thinking about, are we treating unilaterally here? Or are we treating bilaterally? And I think it depends. When it comes to radiculopathies, there is MRI data that looked at multifidus in folks that had a confirmed radiculopathy at a segment, and they saw multifidus atrophy. I think that's more of that chronic case, though, right? Like multifidus isn't going to atrophy within a week post-acute injury. And so I would almost say, let's get the best pump to that entire nervous system, and treating bilaterally might not be a bad thing to do for that acute radiculopathy. And then thinking about, and that's probably where I would start on day one, is let's just treat around where that inflammatory process is occurring versus kind of following that nerve pathway down the arm. At ICE, right, we're all about less is more. So if we can do less better, if we can treat minimal effective dosage, start there. And then you may have to add layers down the road if we're not seeing those symptoms clear up.
So you respect ground zero, pump above and below is the needling strategy for that acute. And I mean, what you have layered in is a lot of like pain science, patient education stuff, because what you immediately said with your rationale for what we're doing with needling is this is a chemical irritation, which is going to be different than where I go in a minute. Like what didn't develop overnight is a mechanical compression of the nerve root. Like something occurred, maybe there's an annular tear, maybe there's some tissue disruption, but fluid-based biochemical, like nutritional chemical irritation. And then what do we do with it in the clinic is anything we can do to pump it out, to evacuate those biochemicals, to nourish the tissues. But nothing in your explanation to me, and I assume to a patient, is this nerve is mechanically being compressed and we have to find ways to reduce that mechanical compression. And I think that's the key. I mean, in your patient-friendly words, like with your onset, with how this is looking and behaving, this is what's occurring as far as the actual injury and tissues involves. Therefore, this is where we go with our treatment.
Yeah, definitely. And then I think needling is very effective and as a pump, but there are so many other tools that we can use in our toolbox for the radiculopathy as well. But I always want to preface that with like the same thing that I just mentioned is we don't want to throw every tool we have in our toolbox on day one, because if they had a flare up in their symptoms, you never know what did it. Or if they had an improvement of their symptoms, you don't know what was the most helpful. So I think sticking with like one or two, really what you think are going to be the best bang for your buck on that initial session, and then kind of going from there.
So what are those things? They come in, you just pumped above and below 5 to 10 minutes of just muscle pumpy E-stim. What's the rest of that session look like?
Yeah. So I would probably, depending on their tolerance to it, like some oscillatory traction, cervical traction, where you're kind of on, off. I would probably stay away from peripheral like nerve glides, especially if they're having a high like peripheralization of their symptoms, and then layering in some of that McKenzie method, the cervical retractions, again for home exercise program. I love just like a regular cervical retraction, but then I also like a cervical traction with retraction. So like you can do that manually, give them some give them some distraction, some traction, and then have them go into retraction. If you guys you're not seeing the video, Paul and I are demonstrating a lot of retractions. You'll see a lot of double chins here. But how I would set that up for home is like a banded cervical retraction. So they have a heavy resistance band attached to an anchor or like a railing or something. And then that's pulling them into a slight distraction and then layering in some retraction into that band. I think gets a little bit of both that decompression, not a mechanical decompression, but giving that nerve root more space, and then the pump with that retraction. So
love that.
Less is more. 3 things, right? Needle.
Without even tripping over your words, you said retraction with distraction several times, which is impressive alone.
Yeah. But yeah, so that's kind of like that acute flare up day one and giving them that one exercise of that cervical retraction and then going from there. And this is someone that typically with an acute radic, like you want to see them pretty quickly after that. So we're
Yeah.
not waiting a full week to reassess those symptoms. We're having them come in maybe 2 or 3 days after that initial session and just seeing how they tolerated that and where you might need to go from there.
Yeah, and these patients are willing to come see you every day in that week. Like if you're listening and you see this patient, I mean, they're coming to see you on your lunch hour, after hours at your home. I mean, it's like see you or go to the ER. Like it's that
Yeah.
acute nerve pain. So when you say I'd love to see you tomorrow, the next day, like let's just stack up a few sessions, totally appropriate, and these people are willing to do it.
Yeah. Yeah, definitely.
So put you on the spot, and we're being real
Great.
here. We only
Great.
100. Have you ever made that acute disc pain or acute nerve pain worse?
Trying to think. Not as much in cervical spine. I have gotten too aggressive with needling and like flossing exercises too early, primarily in like a lumbar radic. I'm just like, oh, there's nerve involved. Let's give them nerve flossing every 2 hours, right? And sometimes, especially if they have a heavy amount of peripheralization, just even going through that, even though a floss, right, you're not tensioning the nerve through the system, but that can even be too much of an irritant for them.
Yeah.
I think that's where I've irritated some people. And then, we mentioned how you want a needle at first session is straddling. Well, when I was a little bit more aggressive with my needling earlier on in my needling career, I would just like hammer so many segments and hit the one close to home. And that probably was a little bit too aggressive of a dosage. Um, so yeah, so I haven't seen it as much in the cervical spine. And I get some cervical these days. I treated a lot more of cervical earlier in my career, and I'll get cervical when my pelvic patients have like gotten out of pelvic dysfunction. They're like, I have this chronic neck thing. So I don't see it as much anymore. So I don't have a ton of recent data.
Well, and let's go down that road in a minute because, well, first of all, my answer is the same. It's like I have definitely made things worse. Surprisingly, it doesn't seem like it was the needle that made it worse. And like you said, this is even back in earlier needling days where I was more aggressive and I was more aggressively trying to get ground zero, maybe too soon. Even when you have like that discomfort from the needle, which is pretty obvious, like, oh, I feel that shooting down my arm from a needle that I just placed. It never
In the
seemed like that
multifidus.
made things completely worse. What made things completely worse was positioning, like being too aggressive, even just more lumbar, but sometimes cervical, just laying prone for too long in that cradle, or being too aggressive with the repeated movements or the nerve glides. So definitely respect the irritability and I guess just the normal healing timeline or cascade, being too aggressive. And maybe even to my earlier self, I would say being too aggressive or too going to ground zero too soon. I mean, like you said, your first answer was respect ground zero, go above and below. And we're saying visit one, but maybe even visit two. I think over treating, if it's an obvious C6 thing, I think focusing on C6 too soon, it opens the door for potential, I don't know, over treatment. Versus if you step back and say, we're pumping muscles, we're improving thoracic mobility, we're kind of cueing for global movement and posture. And even just like, if there's one thing I can do to get your heart rate up in the next day or two, like
Totally.
these are things that are all correlated to like better outcomes versus saying, Gladys, this is clearly a C6 thing. So I'm going to put a needle at C6. I'm going to get my bony fingers in to get some glides in at C6. We're going to try and tension that nerve that's the median that's supplied by C6. Like, I think if your focus is too close to ground zero too soon, needles are not. Those were my early mistakes for like making it worse, not better.
Yeah, agreed for sure. I love your point there on getting the pump, like the cardiovascular pump. That's, I think, one of the best things that you can get people doing in that acute radic phase, an echo bike, like especially cervical, like if they can get their arms just like gently moving and stuff like
For
that,
sure.
Yeah, that's great.
Yeah, the pain science mental jujitsu of like, we're going to be on a bike, very safe for your spine, very safe position. Your spine's not even moving. Like whatever you can do to convince that patient that we're getting on this bike because it's better than the other the cardiorespiratory like machines, so to
Hmm.
speak.
Yeah.
So when they're like, okay, I do feel safe just sitting here on a bike for that cervical patient, like, yeah, I can, at the least, I can pedal with my legs, right? Like, even in
Hmm.
their mind, they're like, there's no way I'm going to make my neck worse from using my legs, right?
Yeah.
And it
Love it.
works. All the
Yeah.
data we have says the people that move the most and move the soonest do the best.
Yeah.
So now let me pivot to where you went, which is chronic. Now it's not a younger person. It's someone who's been sitting at their desk every day for a decade. And there wasn't a specific, did this thing and made it hurt. It's the gradual, like, yeah, my neck was kind of bothering me for a few months. Then I started to get this lateral elbow thing, and then I started to feel numbness. And I mean, unfortunately, what we're saying now is maybe there is a mechanical component on board, like
Hmm.
maybe the osteophytes and the degeneration, and if they had an image or not. But now it becomes a little, our brain starts to think a little maybe less biochemical bloodbath around around an exiting nerve root. I'm sure there's still chemical irritation. I mean, just
Yeah.
systemic inflammation. So some of those things still hit. But do you treat that person differently than the younger, more acute cervical radic?
Totally. And I think with the chronics Radics, you see you kind of see two different people. You see the people where that discomfort's kind of lingering all the time. And then you also have the folks that have chronic, but then they have acute onsets too.
Yeah,
So,
for
and
sure.
that's where that like chemical irritation piece comes into play too, because things can tolerate a decent amount of mechanical pressure. Like if you think about how much pressure or compression or whatever you want to call it, your nerves get every single day, like going through your body, they can tolerate some mechanical pressure. It's really the chemical irritants that they don't tolerate. But for the folks that, yeah, it's like every single day they have that nagging neck pain, medial clavicle or medial scapular border pain, all of like that sign, then yeah, you can probably get a little bit more aggressive, not like overly aggressive, but you can go a little bit closer to home with your treatment. So, and you can treat a little bit more heavy handed with the amount of needles trying to get, because we might have some chronic nerve change. We have probably decreased conductance and things like that. If we're getting actual muscle weakness and chronic numbness, tingling, those sorts of things, we're actually seeing changes in the nerve itself. So we want to treat the nerve itself versus just getting that pump around the nerve, right? So cervical spine, that's where things are originated. So you want to make sure you're tackling there. I think you could probably get closer to that ground zero, like you were saying. If it's a C6 Radic, like maybe we can put a needle in C6 now. If we're thinking about changing, or do we need to treat bilaterally versus unilaterally, this is the case where I think we have some of that multifidus atrophy on one side. So making sure that we're definitely treating that ipsilateral side to the symptoms. I think treating bilaterally has its merits, but when you're connecting E-stim to it, making sure that we're connecting like tissues with each other. And when we have multifidus atrophy, we want to make sure that we're connecting those two together for sure. But it's not something that you have to treat bilaterally necessarily. And then kind of figuring out, do we want to follow that nerve down the extremity as well? So there's kind of two main techniques that we can do for there. We can, well, really three actually. We can do perineural technique, right? Which is we're creating a pump in muscles that surround the nerve. I think that's also where we could go with in the acute radiculopathy. As symptoms have centralized, we can start treating around the peripheral nerve as well. And then in the chronic case, getting closer to the nerve itself with some peripheral nerve stim. And that's like, there's tons of data out there that can improve nerve function. And so that's where I would go there. And then depending on if we have myotomal weakness as well, you can start layering in some of those key myotomal muscles for for that cervical segment, and then potentially even needling the muscles that are impacted as well from that, like if they've had muscle atrophy, needling those specific muscles and getting a good pump there and improving contractility and stuff like that. So that was a lot of information.
No, but what's fascinating is we're saying the exact opposite of the acute one. Like we respect ground zero. We're kind of just finding ways to pump the neighborhood or pump the region or pump the human. And now it's like, man, what is even comparing dry needling to some of the other options we have is like, man, high value in being able to put a needle on a 6 multifidus. Like, yeah, and if you read the Chan Gun playbook, I mean, the tonicity of multifidus having the potential to close down those exiting spaces for nerve roots. So both the mechanical component and then the medial recurrent branch of the dorsal ramus being what wraps around and supplies multifidus, plus the disc and the annulus, like a little neurologic portal to that sensitized dorsal root. So, and then even in the periphery, do we have anything so specific? I mean, I guess we can glide nerves, we can tension them, but no other tool can we stimulate a nerve directly aside from a needle with e-stim.
Yeah.
Which is beautiful. So, I mean,
It
it's
is.
the specificity is the power. I mean, the nervous system response is the influence we're looking for, but the ability is fascinating. And yeah, I think in that scenario, we do want to target ground zero. And again, Chan Gun would target bilaterally. I mean,
Yeah.
we have data that even that posterior lateral disc protrusion or that unilateral nerve presentation, we have type 2 fiber loss of multifidus bilaterally. Some of the whiplash data says fatty infiltrate doesn't occur just on one side, it occurs on both. So, and maybe there's other reasons, but yeah, I don't think we're afraid to treat both sides, even though we know it's a single side.
Yeah. You want to talk us through it, where this conversation also stemmed from?
I'm
What you're
asking for a close
a
friend.
friend?
I've had what feels now like a C6 for Dick for, I mean, it started last summer. So, I mean, and it was handstand push-ups. So, I mean, I'm not that youngest.
I was going to ask which category you fall into.
Let's not focus on the age for a moment. And I considered it more of that acute onset, and I kind of pain scienced myself into that. So, yeah, I mean, the Cloward referral pretty quickly became lateral elbow, and then shampooing my hair, feeling numbness in the digits. So, I mean,
Yeah.
as much as I wanted to deny what was happening, when I clustered those symptoms together, I'm like, I think I know what's going on here.
Yeah.
And it got better. Honestly, over the holidays, I wasn't traveling as much because I mean, everything you hear patients say, I have now experienced, which is I feel good when I work out. I mean, I've avoided some things like handstand push-ups, but otherwise, I'm really not changing. I'm still sending the workouts, and I feel better afterwards. In fact, what revs it up the most is the 5-hour flight or the hour drive to the airport or even just standing and teaching. Like if you've been on a course with me recently, I'm sure you've seen me just sitting there rubbing my
and
neck.
retracting.
I try to do my retractions. Cause yeah, it's just that static posture that bothers it the most. And I mean, the nerve pain is not back, but that like gnawing scapular Cloward referral is, and it's
Yeah.
because I mean, I'm teaching a lot more these weeks. And so, yeah, that's what spawned it. But I mean, and I get treatment when I can on courses. And I do my homework when I'm home, but I have not been as diligent as like to go see Brandon or Jenny at Onward Bellevue, like for once a week or twice a week type stuff. So
Yeah.
I think I'm the opposite. You said those chronic folks are often acute on chronic. I would say I'm acute and now I'm more chronic.
Yeah.
I'm
Yeah.
a chronic on yeah, whatever. That's probably a natural transition, but
Yeah, for sure. It's definitely become chronic. You have some weakness and
yeah,
stuff
pec,
there.
which is an
Yeah.
interesting
Yeah.
because I mean, yeah, just the lateral elbow and the numbness pattern and the Cloward referral. I mean, I'm pretty confident it's C6, but the pec atrophy was unexpected for me.
Interesting.
But
Yeah.
that's actually the main lingering impairment.
Yeah.
So
I
I
want to needle your
get
I want to
needles when I
needle your
can.
peg.
I'm going to be
Yeah.
with you in Raleigh this weekend. I mean, I have been as diligent as to start doing some BFR upper body
Cool.
stuff. And I'm curious
Yeah.
to see if that will do anything for a pec, but I'm taking it more
Interesting.
seriously. And I can actually hide really well in most workouts, but when push-ups or bench press show up, it is very obvious that I'm
Yeah.
still weak.
Here comes Murph prep. Better do
So
those
yeah,
push-ups.
if you're listening and you have any sage advice for me, that would be lovely.
Yeah. Well, cool.
Otherwise, thanks for chatting the needle stuff cervical radic today. Any missing thoughts?
No, I think the only thing that we have kind of played around with, which we can have a different conversation, but Easton parameters for that. We've
Good
kind
call.
of dabbled with different dosage. And for me, I have a little bit of the same. I have like a constant Cloward sign, but I also have like a really hypertonic paraspinals on that right side. And so I've actually found that higher frequency does such a good job at like reducing that tone around the exiting nerve roots and things like that. So I have played with, higher frequency for treating that. And I think we trialed it with you one time and it was tolerated fairly well. So
Yeah. Is 30 hertz? Are you going higher
yeah.
than 30 yet?
No, 30 is typical. I definitely tried higher than 30, but no, I think the 30-10 setting is fine. You're getting slightly out of tetany, so you're not kind of always in that tetanic like, muscle contraction. But the higher frequency, really gets those muscles to relax. You get some, endogenous opioid
Yeah.
production, those sorts of things. So there is some value to trying higher frequency.
Yeah, and if you're not tracking at home, I mean, if you have the ES160, there's a fast, slow, alternating setting. It goes back and forth, and I mean, it's programmed in the unit. So if you go up for 30 seconds, if that's your high setting, it's just programmed to be set with 10 hertz, which is low. So you kind of get a higher pitched cramp threshold, and then 10 hertz
It's fluttery.
technically is below tetany, but sometimes it's hard to tell. But yeah, I mean, we tiptoed our way up there. We didn't just
Yeah.
send it right out of the gate, but I enjoyed it, and I like.
Yeah.
And I mean, there was a really nerdy neuropeptide study that said when you get north of 20 hertz, you start to titrate and drip some dynorphin. So I mean, the lower frequencies, do you get pain modulating stuff? For sure, but it's your less powerful, but honestly longer lasting endorphins and beta enkephalins. But then, the higher frequency dose in this one study started to drip the dynorphin, which is way more powerful. Doesn't last as long, but if you're looking for that really powerful short-term analgesic thing, try tiptoeing up into higher frequencies.
Yeah. Play with it. That's all I got though. So
Love that.
yeah, where can people find you on the road? We're both gonna be in Raleigh this weekend, but
Raleigh's, can't wait for that. You're in
I
charge.
know.
I'm just there
so
as
excited.
your
Paul's my
support.
TA.
I'll be running the smoke and lasers, the AV. Like, I'm just behind the scenes.
Yeah.
So
but
we've
you
got
got a lot of
Raleigh,
courses coming up. Yeah.
then Easter, then an advanced course in Bellevue here at home in Washington, then an advanced course by you in Longmont, Colorado, then Charlotte, then back home for like a lower in Bellevue. So yeah, 6
Nice.
out of 7 is the warpath that I'm on this next month.
Nice. And then we have Sampler coming up, so that'll be fun.
Middle of May.
We're gonna be at Sampler for lumbar. Lumbar, I guess.
You and Pat running the session there for needling.
Yeah. Yep. That'll be fun.
Where are you going to be aside from Raleigh?
Raleigh this weekend, and then I have a couple weeks off, and then I think I'm going to be in Newton, Kansas after that for, I think it's upper body, and then I will
love those folks at Empower.
Yeah, I know. They're great. I love Addison and his team, so that'll be really fun. And then I have Sampler, and then at the end of May, I have my next pelvic live dry needling course, May 30th and 31st, and that's in Longmont here. So home turf with Megan. So we already have 11 signed up, or
hell yeah.
No, 12 signed up. Yeah.
It'll sell out.
So that'll be a fun weekend. So that's what I got.
All right. Well, thanks for tuning in. Can't wait to see you in Raleigh.
Sweet.